Okay, this presentation deals shortly about our experience with high-risk cancer. And I mean, most of you have seen radical prostatectomy versus watchful waiting in early prostate cancer. And in the New York Times, this academic presentation was taken off by New York Times, and many of these men would do just as well to choose no treatment at all. If you look for other statistics, that is not the reality. We have an incidence, and that is the cancer statistic of 2012 for America, 29% incidence for new cases, and the mortality rate in prostate cancer is in the second place with 9%. So this wait and see is maybe not the right thing, especially not for patients which are under high risk. What we have treatment modalities for these patients is androgen deprivation therapy, radiation therapy, plus anti-hormonal therapy, and surgery and radiation, and again, anti-hormonal therapy. I just want to bring you what might be the reason why we want to have local therapy in T3, T4 patients to avoid rectal and bladder tumor compression and infiltration, to delay tumor cell spreading from local primary tumor, to destroy locally non-hormone sensitive tumor cells, and to prevent intravesical, supravesical obstruction, bleeding, or pain. So secondary goal and the hope is longer survival, better life quality, induction of immunitary responses, as we heard just a session before, very interesting data, and less cellular selection by a hormone ablation. Now, we did a cohort study in Munich with 480 patients, so the main point, T3, T4, or PSA over 20, Gleason 8 to 10, and 0 and M metastasis free. So we treated these patients, and you see the 10 years result in this group, where was cancer-specific survival at 10 years with 92%. I cannot bring all the different statistics because of time reason, but when you look on the right side, you see the complication rates were relatively low, especially if you compare it with radical prostatectomy. Now, the summary of these, 57% did not need salvage treatment at 10 years. Salvage treatment, whatever kind. 40% controlled biopsies after HIFU. So the results also gave the suspicion that there is little more involved in that, and that is maybe a modulation of immune response. And when we look in the literature, there are a lot of theoretical data with that, but from our clinical side, we think there must be more than just the local destruction. And we had 2 cases which were metastasized and had advanced disease, and we could treat them with a combined treatment and make them tumor-free. So in this study, HIFU treatment had a strong impact on PSA. We had a 26% HIFU retreatment rate, but in 90 to 97%, we could postpone anti-hormonal treatment, which means a lot for the life quality of these patients. If you compare it with a statistic about radical prostatectomy, 10-year cancer-specific survival, you see 95, 92, and our current study, 93%. 10-year metastasis-free survival, 89%. In our case, 91%. So I think it might offer, in special cases, significant advantage for the patient to do HIFU even in before excluded high-risk patients. Okay, thank you.